Okay, so I think we are ready to begin. And may I welcome you once again to the CSW Parallel session entitled Innovative Community-Led Approaches to Advance Women's Health and Well-Being. My name is Dr. Teresa Castillo, and I am the Chief Program Officer of HealthRight International. It is my great pleasure to be here today and serve as the moderator for this session. We are so excited to celebrate the significant milestone in the global women's rights movement, the 30th anniversary of the Beijing Declaration and Platform for Action. This foundational agenda was a catalyst for gender justice, which in turn spurred a plethora of governmental gender equality initiatives worldwide. This declaration outlines 12 key areas for urgent action. Next slide, please. Oh, yeah. These include women in the environment, women in power and decision-making, the girl child, women and the economy, human rights of women, education of training of women, violence against women, women and poverty, institutional mechanisms, women and health, women and armed conflict, and women and the media. These 12 areas are so important and have undergone a huge transition, shifting in a positive light. Today, you will hear about HealthRight International's innovative work to advance women's health and well-being across a number of these key areas. For those who may not be aware, HealthRight International is a global NGO that was founded more than 30 years ago by Dr. Jonathan Mann. Our mission is to ensure equitable access to quality healthcare for marginalized populations. We believe in the fundamental right to health and focus our work on 4 integrated, overlapping health issue areas. Those are reproductive, maternal, newborn, child, adolescent health, also known as RMNCAH, HIV, mental health, and violence. We bridge formal healthcare systems to link to the informal community health system in partnerships with multi-level stakeholders. Our core values of equity and inclusivity, community-led programming, sustainability, and evidence-based work remind us of the formidable progress that we have made, as well as charted the road ahead. So today, just to give you a run of show, we will hear from 3 different perspectives, different country approaches to community-led work. First, we'll hear from our colleagues in Uganda, our project coordinator from HealthRight Uganda, Emmanuel Aboy. He will share more information about our step care model for perinatal depression. Next, we will hear from Anna Sayenko, our Associate Program Director from HealthRight Ukraine, who will outline a revolutionary GBV response to work that's being done in crisis-affected Ukraine. Lastly, we will hear from Helen Chemtai, who's a project officer in HealthRight Kenya, and she will highlight community-based family programming in rural Kenya. At the end of these presentations, we'll have an opportunity to hear from our 2 discussants, Dr. Philbert Murray, who is head of health planning and policy from West Pokot County government in Kenya. And then we will also hear reflections and responses from Dr. Natalia Piven, who's the unit lead on public health and IHR preparedness from WHO Ukraine. We are so excited to have this vibrant, engaging panel. And with that, I would like to invite our first speaker, Emmanuel Aboy from HealthRight Uganda.
Thank you very much, Teresa. Good evening, East Africa, and good morning, New York. I'm excited to be here. Teresa has done a wonderful introduction, and I'm going to be taking you through the Uganda stepped care model for perinatal depression. Next slide. So, as statistics showed, depression affects 25% of the population in post-conflict settings, and this has not been any different in northern Uganda, where 25% of the population has been affected by depression, with evidence highlighting critical gap in community awareness and understanding of mental health. We found this as an evident need that needed our intervention, especially with the Ministry of Health allocating only 1% of its 4.1% of the GDP to expenditure on health. It showed that there was a severe gap and a demand for services with very limited resources available. This put these communities, the post-conflict communities, at more risks of worse mental health outcomes, and specifically perinatal women being at a very higher risk of suffering from depression, which we know it has very adverse effects on the unborn and even born children. Next slide. A key innovation from HealthRight was to design a stepped care model for perinatal depression. This intervention focused on developing an approach which integrates mental health care into antenatal care service points in the primary health facilities, because the interest was to take the intervention deep in the community where there is no specialist, mental health specialist, to support and offer care to the perinatal mothers. The emphasis of the approach is to task shift mental health care work from non-specialized care to non-specialized care providers, along with the supportive supervision from the mental health experts that are within the HealthRight structure. So we realized that this reduces the mental health specialist ratio to patient to mental health specialist ratio, but also able to ensure that we bridge the gap which is caused by the resource constraints, and also ensure that the mental health services are brought closer to the community. This approach has been implemented and still going on in the districts of Lira, Kitgum, and Soroti. Next slide. To put more elaboration on the approach, first, in these circles, right at the bottom, is capacity building or strengthening the capacity of the community. By so doing, we ensure that the lay healthcare providers, like the community health extension workers, are trained using standardized tools to be able to detect and identify symptoms of depression among the perinatal mothers. Remember, all our antenatal care clinics have the VHTs attached to mobilize the communities and sensitize them to accept and take up the antenatal care services. And this very capacity strengthening enabled us to widen the sensitization in the community to enable the VHTs and the community health extension workers to create awareness on the mental health problems, specifically perinatal depression and other mental health conditions in the community. After that, when the antenatal mothers stand up for their antenatal care services, the trained VHTs and the primary health care workers who are midwives attending to these mothers to make an initiative to do a baseline screening, asking 2 cardinal questions on PHQ-2 to determine if the mother has the signs of depression or not. And when the signs of depression are detected on a mother, a further assessment on PHQ-9 is done. And after that, depending on the scores that are good, that the mother obtains, finally, an intervention appropriately is recommended. Either first-line intervention, which is psychoeducation with a follow-up of 2 weeks, or low-intensive psychological intervention, and that's under treatment. If the symptoms are worse, the mother is referred to the next level where she finds support from more specialized mental health caregivers of HealthRight, or she is referred to the psychiatric specialist at the nearest health facility within the community. So we realize that this approach moves in steps, and step one is the prevention and screening. And in the prevention, that's where awareness is done by the community health extension workers or the village health teams within the community who create awareness about the prevalence of the perinatal depression among the mothers. The screening for mental health condition is done, like I said earlier on, and this is when the mother visits the antenatal care clinic for the first time, where PHQ2 screening and PHQ9 is done using the KESLA-6 and PHQ9 screener tool. Finally, in these tools are used for determining the necessary psychological first aid intervention that the mother needs. And specifically for HealthRight, we ensure that doing what matters in times of stress was the necessary intervention that could relieve the mothers from the symptoms of distress and depression. The second step is the low-intensity intervention. Like I said, after the prevention and the screening is done, those with the higher symptom scores are enrolled into low-intensity treatment intervention that are again provided by lay non-mental health specialists who have been trained by HealthRight through capacity strengthening to ensure that they are able to offer self-help plus, problem management plus, or interpersonal therapy, depending on the determination of which intervention can benefit the mother. Also, individual psychotherapy by the clinical staff when necessary are provided, and where the symptoms persist after follow-ups, a referral to specialized mental health care is done, where medication is prescribed and further management. Step 3 of this is the community-based recovery support, peer support groups, referrals for long-term care is done, referral to social support services. For example, we have the mothers coming together in groups to ensure that they engage in income-generating activities, but also continue supporting other mothers who are struggling with the symptoms of distress, and also linkages to mental health advocacy networks that are existing within the community is done. Next slide. In a summary of the steps, the model has basically 4 steps. And step 1 is initial screening that I've explained earlier on. And this is done by a nurse or a midwife during the antenatal care visit or the VHT. And what is used here is PHQ9 screener, PHQ2 and PHQ9 screener. The PHQ9 is used if the scores in the PHQ2 point towards depression. That's on a score of 2 and above. Then the mother will be taken through the PHQ9 screener. And step 2 is basic management. And this is done by the VHT, whose capacity has been strengthened. And basically, this basic management is the psychoeducation, making the mother understand what is making her feel the way she is feeling. And it's proved that this first stage of basic management helps to relieve the anxiety and eventually reduce the symptoms of depression. Step 3 is the intermediate psychosocial management, where mental health psychosocial counseling trainees within the Docket of HealthRight provide these interventions. And these mental health psychosocial counseling trainees are people whose capacity has been strengthened and they are within the community. Group interpersonal therapy is also provided in case the symptoms still persist. And step 4 is specialized psychiatric management. And this is done by the psychiatric clinical officer, where pharmacological therapy is done, where medicines are recommended for some doses of antidepressants to support the mother whose symptoms have persisted after the psychological interventions. Next slide. So we realized that there has been a lot that has been achieved. A total of 22,139 mothers were reached, and all of them were screened for depression across the period of the project. And you realize that 41%, that's 9,140 of the screened mothers actually pointed towards the signs of depression, and upon subjecting them to PHQ-9 screener, 25.8% had symptoms of depression. The capacity has been strengthened, where mobile primary health care workers, these are the midwives, the nurses, have been trained, and a total of 75 have been trained. VHGs, 115 of them have been trained, so we've been able to build a capacity of 190 non-mental health specialists in the community to be able to provide the mental health services for the perinatal mothers. Next slide. There are notable strengths of this model. One is that the model can be locally adapted. All the tools that we used were adapted to the local context to make them usable for these non-specialized mental health care providers, but also to make it fit into the context of the community for their understanding of the word depression and what it means in their community and in their local context. The model has the ability to build the capacity and to strengthen the capacity and enable task shifting from this. Instead of focusing on looking for the specialists, we can shift the task to non-specialized mental health care providers who are able to do the same service and support many mothers. This is very effective for the resource-limited settings, because we can't dream of a time where we are able to have mental health specialists in all these communities. By doing this, we are able to ensure that the limited resources are utilized and many people are able to be trained and provide the services to the community. This has also enabled the extension of mental health services to the most vulnerable persons, and also improved adherence to antenatal care has been noted, where mothers have been able to turn up for the antenatal care services because the midwives eventually spoke to their hearts. They spoke to their hearts. By the midwives understanding the symptoms of depression, they were able to treat the mothers with gentility, and the relationship between the midwives and the mothers was strengthened, and adherence to antenatal care was improved. Next slide. We have the next slide. Key achievement is that this model has been scalable, and we're able to scale it up and adapted it for an urban informal settlement context in Kenya, which has been supporting mothers for the past 3 years. I think that marks the end of my slides for now. These are pictures showing the VHT, or the village health team member, checking the mother through psychoeducation after PHQ-9 screening. These are motherhood symptoms of distress. The other picture where you see many blue t-shirts are the VHTs going through a supervision and mentorship session by the mental health technical team of HealthRight. The other picture was during the training of the VHTs. They are opening the tools that they are using for psychoeducation. And the last picture on the right, the bottom right picture, is the mental health counselor taking the patient through health talk, talking about the signs and symptoms of depression.
Thank you, Emmanuel. Thank you so much for your presentation. And from Uganda, we move to Ukraine. I invite our Associate Program Director, Anna Sayenko. Thank you.
Thanks, Therese. Good morning and good afternoon, everyone. It's an honor to present before you today at this parallel event during CSV 69 and representing HealthRight International in Ukraine and its local entity, the Ukrainian Foundation for Public Health. We are gathered here at the critical moment. As we mark 30 years of Beijing Platform for Action, we must acknowledge that gender-based violence remains a global crisis, and a crisis is magnified in times of war. For the past 3 years, Ukraine has been an epicenter of one of the world's most devastating humanitarian crises. The war is not only led to loss of life and destruction of homes, but has also depended vulnerabilities for women and girls, exposing them to sexual violence, exploitation, and trafficking in alarming rate. But let me be clear, this is not just about Ukraine. The lessons we are learning and models we are building and the solutions we are implementing are shaping for future of GBV response worldwide. Today, I want to take you through the survivors-centered, digital-first, and integrated model that is transforming GBV prevention and response in conflict settings. Before full-scale invasion, Ukraine already faces structural challenges in responding to GBV. However, since 2022, over 10 million people has been forcibly displaced, 56% of them women and children. An estimated 3.7 million women need GBV prevention and response services. Cases of conflict-related sexual violence has been documented in occupied and recently liberated areas. These numbers are more than statistics. They represent real women, real families, real lives shattered by violence, displacement, economic devastation, and collapse of support services has created a perfect storm, leaving survivors without safe spaces, without legal protection, and without support. But despite these immense challenges, we are not powerless. We are pioneering innovative survivor-centered solution, but we are reshaping how we prevent and respond to GBV in times of the war. Next, please. Our approach is to build the simple of powerful principle. Survivors must receive support at every stage, from prevention to emergency response to long-term reintegration. First, when we're talking about awareness and community engagement, it must include nationwide awareness campaign, educate women to their rights and available support, engaging men and boys to change harmful social norms, training first responders, ensuring that doctors, police officers, and social workers know how to identify and assist survivors. The next step is about innovative models. So, for example, our Safe Women Hub online platform. Imagine a survivor trapped in the occupied territory, isolated, afraid, with no safe way to seek help. What if she could access immediately support with just one click? Safe Women Hub is secure online platform that provides confidential psychosocial support with trained professionals, legal consultation and crisis intervention services, discreet immediate assistance even in high-risk areas. This digital-first approach is revolutionary for survivors to access to the care and ensuring that even in war, help is always within reach. Next step, which we include in our activities and operating, it's our integrated survivor support through response and care units. We name them Brave and Safe. For survivors, navigating multiple services can be overwhelming. We have changed that. Our Brave and Safe centers provide medical care, including dignity kits, STI prevention, provide trauma-informed psychological support, legal aid, and case management, and provide safe space for recovery. Everything under one roof, because survivors deserve dignity, not bureaucracy. And the last of this model is our halfway houses as a path to independence. Survivors do not just need rescue, they need a future. Our halfway houses provide safe shelter for survivors and their children, vocational training and job placement, long-term reintegration support. We are not just helping women escape violence, we're ensuring that they never have to return. Next, please. As we commemorate 30 years of Beijing Platform for Action, our models directly support two crucial commitments. First is eliminating violence against women. We provide rapid multidisciplinary support, ensuring that survivors are heard, protected, and empowerment. And second one is women and armed conflicts. We are leading efforts to documenting conflict-related sexual violence cases, ensuring that survivors access justice, medical care, psychosocial support, and rehabilitation. We are working within Ukrainian government, UN agency, and global partners to ensure that these services become permanent, not just emergency intervention. Legal protection for survivors are stringent, and GBV response is embedded into Ukrainian national recovery strategy. This is not about today. It's about ensuring that our daughters and the next generation live in the world where GBV is no longer tolerated. Next, please. Through this work, we have identified three game-changing innovations. First, it's digital access via Safe Women Hub. It's bringing discreet, immediate support to survivors, no matter where they are. Next, it's our integrated service models through Brave and Safe centers. It's one-stop solution that ensures survivors receive all necessary support without unnecessary delays. And our long-term reintegration via halfway houses and economic empowerment, because escaping violence is only the first step. True empowerment means financial and social independence. These approaches are working and they can be adapted on other crisis settings worldwide. Next, please. So what comes next? How do we ensure that this progress does not stop here? It's about increasing donor investment, and we understand that the GBV services cannot rely on emergency aid alone. We need long-term funding and long-term support. Also, it's about policy adaptation and institutionalization. Governments must embed these survivor-centered approaches into national strategies. And last but not least, yes, it's about stronger civil society networks. Local and international organizations must collaborate, ensuring that survivors have continuation access to care. This is a defining moment. we have solutions, we have evidence, and now we need the actions. The war in Ukraine has tested us. It's exposed our weaknesses in GBV response, but also highlight our strength, our resilience, and our ability to innovate. Our work is not just about responding to crisis, it's about creating new standards for GBV response worldwide. Let me leave you with this. What we do today will define the future. If we act boldly, strategically, and commit fully, then survivors in Ukraine and behind will not longer have to fight alone. And at this moment, it's time to lead. Let's not waste it. Thank you for your attention and so that you joined to this event today.
Thank you, Anna. Thank you for sharing the experience of our HealthRight Ukraine team. We've heard from first our colleagues in Uganda sharing their experience in a post-conflict setting, to our colleagues in Ukraine who are diligently and resiliently providing care and services during an active war. And so there are many lessons to learn about innovation to this point. I'd like to now invite our Kenyan colleagues to present. Helen Chemtai, who is our project officer in Kenya, will share some of our innovative programming related to community-based family planning. But before she begins the presentation, we'd like to share a short video of our work there.
Challenging sociocultural norms and limited programming for adolescents and women with disabilities are common barriers to accessing family planning in rural Kenya. HealthRight International has shown that home visits by community-based distributors to be a promising strategy to close the gaps in reproductive health care among poor, rural, and semi-nomadic communities throughout the country.
Now we have empowered community-based distributors who understand the need to reach out to every member of the community.
HealthRight's work affirms that providing inclusive education and care to the most disconnected members of one's community and engaging all of its members can transform families and empower women in their reproductive lives.
Thank you so much, Teresa. Thank you so much. Good morning, good afternoon, good evening, distinguished guests, colleagues, and participants. Thank you for joining us today for this important discussion on community-based family planning in Kenya. My name is Helen Chemtai. I'm the project officer, and I am honored to present the impactful work being done to improve family planning services in marginalized communities across counties in Kenya. As it is in Beijing, as it said, the Beijing Declaration affirms women's rights to control their sexuality, including their sexual and reproductive health, free from coercion, discrimination, and violence. It calls for access to comprehensive healthcare services, including family planning, to enable women to make informed decisions about their reproductive lives. Okay, next. Today, I will share insights in expanding family planning access through community-based family planning, whereby we have implemented programs to increase family planning access in marginalized communities in Kenya, focusing on adolescents, people with disabilities, and rural women. Distance from households to health facilities has been contributing factor to poor family planning uptake, and this initiative of community-based family planning brings information and services directly to community to eliminate the need for traveling to health facilities. That is through the training. We trained certified community-based distributors to provide services at beneficiaries' homes, overcoming transport and time constraints to the facilities and waiting time as they queue for services. Cultural barriers has also been addressed. They tackle myths and misconceptions and lack of reproductive health awareness among young women at the community level. Community-led initiative also engaged men and religious leaders and youth led groups to foster support for family planning reproductive health. As it has been an issue in our communities, men have been known to be hindrance to family planning uptake, and implementation of male engagement program to support increased access of family planning services in collaboration with religious leaders who lead in different denominations in decisions to family planning services uptake, and youth-led organized groups who promote family planning awareness and use to their peers. Next. Our implementation approach was majorly using a phased approach in the program, which relied on the Kenya Health Information Systems for data to explore the regions with the highest populations for women of reproductive age with low family planning uptake. This Kenya Health Information Systems also was helpful for us to work with the counties that had low family planning modern contraceptive prevalence rates, and in close collaboration with the national and county health departments, with support from the community leaders and religious leaders, we are able to implement this initiative. For community-based distributors, it was derived from 4 community units in one of the sub-counties. This was a pilot, and were vetted using a minimum selection criteria that included O-level education and ability to read and write. Basically, this is not a criteria when selecting all the community promoters, but because this was more intensive initiative, that's why we wanted to get some people who are able to read and write, and that was one of the criteria that we brought on board. A comprehensive 16-day training program followed by a 2-month facility placement for a practicum sessions, whereby 20 community-based distributors were certified to assume community-based family planning services at the community level. So this was now, we had now the empowered community-based distributors who are able to provide services from door to door to ensure that those women who are needy at the community level, the poor rural women, were able to access the services at their doorsteps without encountering challenges to travel to health facilities, which is quite far from this, that having quite a distance from the facility level from a host level to the facilities to access services. Next. Some of the impacts we realized during this implementation period, and this was a period of 3 years that we implemented. We achieved an increased modern contraception use from 14% to 23% for West Pokot County, and that through male engagements, we had a greater involvement of men in family planning decisions, fostering shared responsibilities in reproductive health, as they have always been known to be decision makers and influencers in our communities. So engaging them was really a positive move, and we were able to reach more women, get the services, the family planning services. We improved access to family planning services in remote areas. We also increased acceptance of community-based distributors due to integration of male community-based distributors, because men who used to resist this approach also felt that it was okay for their own also providing these services. There was also improved family planning data collection because we worked in collaboration with the Ministry of Health reporting systems, and we ensured that reports from level 1 were tracked to the highest level and even reflecting to the Kenya Health Information Systems for our impact. There was also increased number of persons with disabilities receiving family planning services, because this is one of the aspects that had not been factored in even from the reporting tools. Persons with disabilities had been left out, but this approach brought in the fact that at the household level, they are also identified to be persons in need, and they also access the services. We enhanced community awareness through chiefs barasas, through the community dialogue days, and other forums that our community health promoters and community-based distributors were given opportunities to share and inform and educate the communities about family planning services. Next. Some of the lessons learned. We learned that the comprehensive community-based family planning training, combining classroom and clinical placements, enhanced community health promoters, clients, interactions, skills, capacity, and confidence. This was very important because at first, they always knew community health promoters as just people who promoted health through education, but now they are offering services. So when they saw them at the facility levels offering services under the supervision of healthcare workers, they gained confidence, and at the community level, they were now able to receive services without strain or without any challenges on the fact whether they were certified or if there were any capacity issues. So placement and practicums were very important at this point. Another lesson learned was that the facility staff and community health extension workers play a crucial role in supporting and recognizing community-based distributors, serving as reference and providing additional assistance. So once this healthcare facility staff worked hand in hand with community promoters, which enhanced the confidence from the community members in ensuring that they were now fully trained, and they were competent enough to offer services. So this in itself won the trust from the communities, and it really increased the service uptake from the community level. Another lesson learned was engagement of local leaders and community members boosted reproductive health service uptake. It has been a challenge over time when the local leadership were against family planning service uptake due to populations. There was a time whereby in Kenya there was this role whereby the political class was fighting family planning service uptake, whereby there was a rule of one man, one vote, 1 shilling, 1 month. So there were counties whereby they really wanted their communities to not practice family planning or child spacing, and this engagement of local leaders really supported and helped boost reproductive health service uptake. For gender considerations increased male involvement and spousal support. Initially, family planning has always been known to be a woman thing, but when men were brought on board, it really boosted the acceptance and even support from the men, and this also increased the services from the community and facility level. Next. Ministry of Health staff were also engaged in routine data quality assessments and supervision to ensure quality of services provided by the community-based distributors at the household level. So this was very important to ensure that it was very important for knowledge retention, to ensure that the knowledge that had been transferred to them was being practiced even when they're at their household levels. So these data quality assessments at the household level was also to ensure that the registers, the medications were well kept, and considering the fact that they're also supposed to ensure that they are not distributing commodities that had expired, and also ensure that they were recording all the services that he had provided at the community level, so that they can register the impact and the level of contributions from what they were doing at the community level, linking to the facilities and eventually to the Kenya Health Information Systems. We also learned that engagement of national facilitators in community-based family planning, county level training, garnering support, uptake for national certification. This was the new approach in most of the counties, and for the national levels were now instrumental in supporting as trainers to the county management teams, who trickled down the training to the sub-counties and the community level. And they were very instrumental in certification process to ensure that the CBDs who were being ushered to the community to offer services had been fully certified by the county and national teams. For literacy, best selection of community-based distributors, improved service delivery competence, because the CBDs were now able to read and write and understand all the units that are taken through, and they were able to document well and even make the requisitions as per the requirements of the Ministry of Health directives. Next. Implementation approach. We have ongoing training and skill retention. We had routine refresher training during monthly community-based family planning meetings to enhance competence and knowledge retention among CBDs. So this was very important because we used to have role plays to articulate the fact that once they are out there, they are able to give the right information and the right services to all women, especially the new users, and even the revisits were able to be well documented and referrals done accordingly. So this training and skill retention was very important during these routine meetings to ensure that they were at par and they were offering the services as per the regulations. Strengthening health system capacity. We equipped health managers with skills to use data-driven decision-making to ensure community-based family planning is integrated into county health budgets, work plans, and best practices. So this was majorly looking at sustainability, bit of it, to ensure that the trained community-based distributors don't end with HealthRight or any other organization that supports this, but also to ensure that the county government takes up this initiative and scale up to other sub-counties and counties. Next. Yeah, so this is one of our success story from Mama Boni. Mama Boni confirms that sometimes when clients go to the health facility, they find long queues, which discourages them. They tend to go back without services, leading to unwanted pregnancies. This is one of our testimonies that community-based distribution has been very instrumental to women at the household level, that they were able to access the services even without the consent of men. And it used to be a challenge when someone has to travel a long way. They had to give explanations, but at a household level, it was easy. And also gapping the gap of distance and waiting time due to the long queues. And as it is quoted here, she says that community-based family planning reduces time spent to the health facilities and transport costs unless it is referral. Yeah, just like we have mentioned that Community-based distributors also used to do referrals, especially for the long-acting contraceptive methods and for the new users. So this was well received, and most women appreciated the approach of family planning, community-based family planning, and we really appreciate this initiative. Next. Thank you.
Great. Thank you, Helen. Thank you so much for sharing a little bit about our innovative work in Kenya related to community-based family planning. At this time, we would love to welcome our discussants who are also close partners of HealthRight, who can offer their reflections on advancing women's health and well-being. Our first discussant is Dr. Philbert Marie, Head of Health Planning and Policy and the focal person for quality improvement for the county government of West Pokot, Kenya. Dr. Marie is a seasoned public health practitioner and a healthcare leader with over 15 years of experience in health system strengthening. He is a medical doctor and holds a master's in public health degree from University of Nairobi. He is also a member of the National Quality Institute and a lead auditor for ISO 9001 Quality Management System. He enjoys traveling, is an avid Manchester United fan. Yay! Welcome, Dr. Philbert.
Yes, thank you, Teresa. And I think I just want to appreciate what the HealthRight family is doing. And I think what we've had is quite touching. And really, I just want to agree with all the speakers who have come before me, especially Anna. We pray that the war in Ukraine ends as soon as possible so that we can be able to help the affected people and provide them with optimal care. I want to thank Emmanuel for his presentation, and really the entire HealthRight family. I think the choice of projects and interventions really is related to really the driving vision for HealthRight International, and we really appreciate the partnerships. We pray that we can continue to strengthen them. And I think listening to Emmanuel, and I just want to confirm that the issue of mental health is really a neglected area, even in Kenya. I know we share a very long border with Uganda, and particularly our West Pokot County. And I think when looking at the data, I suspect the achievement, because you indicated that 25.8% were managed for depression. I think the number should be much higher, because I think you did report that 22,000 were reached, but the ones who were screened were 9,140. So it could be argued that that really is your denominator. So that if those who you are able to treat for depression are over 5,000 out of 9,140 who were screened, then really the effectiveness of that is much, much higher than 25%. So I think we probably need to look at that denominator. And that just goes to say that the intervention is quite powerful and is something that really needs to be scaled up. I'm happy that we have an equivalent of the VHTs in Uganda, that is the community health promoters. And in the Kenyan context right now, we've chosen to strengthen the community health platform as a vehicle for achieving universal health coverage. And therefore that provides a very significant opportunity for us to strengthen this because as you know, the number of workforce trained in mental health is quite limited, and would want to really embrace task shifting. What I was looking out for, and I think it's something that probably you could share with us, is what were the numbers that required specialized mental health treatment from those that were screened for depression out of the 5,000? Because I think it's important also to highlight that even as we task shift for purposes of quality assurance, we still have to advocate for increased specialized mental health practitioners. And I think that detail is very, very significant. But I'm really, really happy with that approach. I think it's a very scalable approach, and we'll really be looking to our partnerships and even the government to really see if we can be able to adopt some of these strategies and be able to scale up even in Kenya, and particularly for me in West Pokot County. I think this is something that we will be excited to partner with all partners so that we can be able to do. This continues to be a very significant need, especially when you rope in the issues of multidimensional poverty that we have, even in West Pokot County in Kenya. So it is something which we really would be interested in exploring and really scaling up as a matter of fact, so that we can be able to do this. I think the issues Anna brought out with regard to GBV are unique, of course, to issues of what is going on with regards to the conflict. And I just want to identify with some, maybe it's not to that magnitude, but we do have pockets of insecurity even in our country. And really the women and children bear the biggest brand of the effects of these conflicts. And therefore, I think we are happy that we could be able to, that these innovations, we can learn from the innovations, see how best we can be able to do this. I know we have a GBV program with us, and the challenge is, again, the kind of budgetary support that we provide for it is quite an issue. Therefore, we need to continue with high-level advocacy to be able to do this. And I am happy with the call to action for Anna. I think that takes priority. But in terms of local context as well, I think this is something that we really need to highlight. And we would really want to learn on the innovations that have really been shared. We have very few rescue centers and safe houses. So I think that is a strategy that we really would want to see how it works out. And just to mention, we would be interested in maybe the, maybe when it comes to presentation by Helen, I think we are excited. I think our county, that is one, West Pokot County is one of the 47 counties in Kenya. And we have one of the highest total fertility rates in the country. And therefore, we are very happy with the HealthRight family for having chosen to pilot this in our county. Of course, much there's a lot more that needs to be done. But clearly, I think we proved the concept that this works. And just to paint a picture, we have a total of 2,423 community health promoters organized in 262 community health units. And therefore, you can see that there is room for scaling up this intervention. As mentioned by Helen, our contraceptive prevalence is still quite low. We are still below 30. And with that total fertility rate, that tells you that we continue to worsen the scenario that we are having. And therefore, this is really high impact interventions that require adoption so that we can be able to safeguard the health of our women and be able to allow them to meaningfully, contribute to society. And I'm particularly glad that the pilot did focus on male involvement, which is a cultural issue that we've really been struggling with in our context. And we therefore really want to just appreciate the effort that went into this. Maybe if we could get the dollar value for training one CBD from the experience from the pilot, that would be really interesting for us. Because I think ordinarily the technical modules for the community level healthcare workers, the frontline healthcare workers, usually is about 5 days. But for CBDs, it's quite lengthy. And of course, that means a lot of resources are expended. But I think it is important to be able to relook this but I can concur, and I did join a few review meetings, and I can really confirm that the competency levels are really where it should be. And but would want, as a matter of interest, and since we from time to time look at the budgeting processes, would be interested in seeing how we can bring down that cost, and maybe having, I don't know, we could do studies to compare durations in training and competency levels. We would be interested in that, because we would want to have scalable and cost-effective interventions with regard to this. So that would be a concern that would want to look at the dollar value for training one CBD. And of course, I think because in our system of government, health is largely devolved, would want to have county level TOTs, trainers of trainers in the various sub-counties, so that we can be able to scale this up. So I think that information we really need to work on. And but otherwise, I think I'm really excited of the kind of information coming out of this pilot, and what has already been shared by Emmanuel and Anna. We hope that we can be able to, do what is necessary. And I want to agree that the call for action is really to increase domestic financing for this, even as we strengthen the partnerships. And we are still reeling from the effects of the famous executive order that I think we are all aware of across the world. So I think the call for action by Anna is really spot on. We need to work out, as much as we're encouraging more support from the donor community, we also need to advocate for increased domestic funding. Back to you, Teresa. Thank you very much.
Thank you, Dr. Filbert, for your perspective as part of the county health management team, and we appreciate your avid commitment and continued support for community-based approaches for advancing women's health, particularly your remarks and highlighting the realities of health systems strengthening the budget constraints and needs, as well as the cultural considerations that are needed. At this time, I'd like to invite our second discussant, Dr. Natalia Piven, who is a public health expert and unit lead on public health and international health regulations and preparedness at the World Health Organization country office in Ukraine. She has extensive experience in health system strengthening, emergency preparedness, and public health policy development. Prior to joining WHO, Dr. Piven served as head of the public health department at Ukraine's Ministry of Health, where she played a key role in shaping national health policies and response mechanisms. She's a dedicated advocate for improving health security and resilience, particularly in humanitarian and crisis settings. We're so honored to have Dr. Natalia with us today. Please, the floor is yours.
Thanks a lot, Teresa. Good morning, good afternoon, dear colleagues, partners, and fellow advocates. It's a great pleasure to be in this parallel session and to present how WHO at country office is working to strengthen the primary health care providers in addressing GBV challenge in the context of war that is Ukraine is over these 3 years alone. So this year marks 30 years since the adoption of Beijing Platform for Action, and it's a landmark movement for the government worldwide and for Ukrainian government in particular, as well as for WHO at the regional level, as recently our regional director Hans Kluge announced the special initiative to address violence against women. 3 decades later, Ukraine, as other countries, specifically those in a conflict-affected settings in the globe, still face numerous gaps in accessing to the healthcare services where the survivor center approach is integrated. Today, I would like to add more what my colleague Anna already mentioned and what we are jointly in close cooperation with the civil society organization, governmental organizations, and communities to ensure that the healthcare providers are really equipped with all knowledge tools, the evidence to ensure they recognize the signs of GBV cases and feel confident and secure to treat such cases. Since 2023, please, next slide, Anna, if you are managing the slides. Thank you so much. Since 2023, Ukraine has documented over 634,000 cases on GBV. And the marks are showing that 14% decrease were notified in 2024. In addition to that, 322 cases specifically related to conflict were documented. And we have to admit that these official numbers are really not comprehensive in that way, that a lot of cases are still hidden and not documented. For many survivors, healthcare system becoming is the main and even only entry point for first-line support. And we always questioning whether the health system is really ready. And we started to work on addressing this problem, honestly saying, at country office in Ukraine in 2021, just before the full-scale invasion of Russia Federation to Ukraine, in cooperation with our civil society, to design how we will approach the primary healthcare settings and actually to align our efforts with the primary healthcare developmental reform in Ukraine. But despite the Istanbul Convention ratified in Ukraine in 2022, but we have to also mention that it was signed in 2019, it's still the gap on the even recognizing the role of health system to address the GBV as a challenge, in particular role of primary health care as a core or center to achieve the universal health coverage. Next slide, please. When we're talking about what is the problem and why primary health care is not comprehensively addressing the GBV, we made quite a short survey among healthcare providers, and we found the key barriers. So specifically, 27% of primary healthcare professionals, including family doctors, nurses, and managers as well, among responders, said that they received prior some of trainings related to GBV. Also, more than 60% of professionals even didn't know about the legal framework that is existing in Ukraine that provides a clear protocol, a guidance, how to treat survivors of GBV. 40% reported that they lack necessary resources, tool, knowledge, techniques, etc., to ensure the adequate support can be delivered if the case is being recognized. Beyond these numbers, there are much deeper challenges. In the context of war, healthcare providers are facing workload, burnout, trauma. Health workers themselves really need the mental health and psychosocial support as well, and they are constantly being targeted by missiles attack. Lack of capacity of primary health care settings actually to ensure that the providers have access to a proper training and to capacitate their knowledge. There is also, despite of having a quite well-developed beyond the health sector services to support survivors of GBV, there is a poor coordination with the health sector. And this is something that needs to be strengthened. And we believe the primary healthcare system particularly could leverage it. So it means that without investing in healthcare providers, in their knowledge to capacitate their understanding of what is beyond, what are the next steps after the recognizing the case, it will put us in a situation of weakness, and this is no time to to postpone the real action to empower and capacitate the healthcare providers. Next slide, please. So how we actually addressing this in Ukraine? I mentioned that we started to cooperate with Ukrainian Foundation for Public Health in 2021 in designing the training based on the WHO clinical protocol for management of rape, and we actually delivered our first trainings for 3 regions right in after the full-scale invasion for the territories that were liberated from the occupation. And we trained and gradually we scaled up, of course, to cover more. And so far we trained more than 400 primary healthcare providers, and we deliberately approach the targeted facilities and train the group of professionals that included family doctors, nurses, and facility managers to ensure they understand the principles of the protocols, the life techniques, the environment that should be created within the facility, and what is the role actually of the healthcare providers and how they can ensure the warm referrals for the survivors to lead further support to other services, legal, social care, on even security. We integrated this protocol into the national regulations to update it, and this is an ongoing process. But meantime, we also already integrated these standards in our training program and distributed through our channels to ensure that healthcare providers already build their counseling and care strategy, which is based on evidence and best practices. Next slide, please. What actually we'll learn from having this training and closely cooperate with primary healthcare providers? Most of them noticed clearly and loudly that they are lacking confidence to working in GBV survivors. They are feeling fear, even saying the wrong thing. If they recognize a sign, they do not feel themselves comfortable to manage the counseling and specific care. So we know that doctors are good in clinical management, but they really need more skills and tools and techniques to be equipped with to deal with the managing this is first steps to provide this first line counseling and understanding what is beyond the healthcare system and how warm referrals can be followed. Next slide, please. So in overall, what was our impact of work? Despite the challenges that we are facing, and actually we accelerated the addressing GBV in health system during the crisis, the huge crisis in Ukraine, we've already trained 80% from trained primary healthcare providers now respond that they are feeling more confident in dealing with GBV cases. We are considering the network of services that already established in communities. We made a mapping of such kind of referrals and shared with the primary healthcare providers, so they are having access to the up-to-date contacts and available services within their territory to provide further support and give this information to the survivors. We also got engaged with the universities, addressing medical universities and also public health schools to integrate the GBV response training package, which is based on the WHO protocols, into the curricula to ensure the next generation of doctors and nurses are better prepared to deal with the GBV problem. Next slide, please. So actually, so to say, when the Beijing Platform for Action was adopted in 1995, it called for health system to play a bigger role in prevention and responding to GBV. Since then, in Ukraine, we are still working hard to ensure that the GBV is recognized by the health system across Ukraine, and the survivor center approach is a basic one to follow. With this, we also have an opportunity that the National Mental Health program is actively working in Ukraine, and it is quite a comprehensive program that allow us also to train the primary healthcare providers on mental health and psychosocial support through the application of the MHGAP tool, but also to provide support directly to the healthcare providers to equip them with the techniques how they can provide self-help and be ready to consult the survivors. In further direction, we understand that we should work as comprehensively with the engagement a lot of sectors. For us, it's quite a challenging when we talk from the health point of view only, when this survivor-centered approach should be integrated within the health system, but also with other services beyond the health sector. For next plan to ensure the sustainability of action that we lead in country office, we consider GBV activities not that project oriented, but to ensure sustainability. We are planning to train more trainers to ensure that the coverage of with trainings is much wider. We anticipate to work directly with communities to work comprehensively together with other sectors to test how the referral system works, how primary healthcare facility is ready, and how to make actually primary healthcare facility a trustful place and place where survivors are confident they can be treated properly, and any support that they may not receive within the primary healthcare, they can be warmly guided to other services to ensure the safe support. So I would stop here. Thanks so much for having me. And I really appreciate Human Rights in Ukraine and Ukrainian Foundation for Public Health to be our close partner in WHO. So together we may do quite a good progress. We have a lot of plans to tackle GBV. Thank you so much.
Thank you, Dr. Natalia. We appreciate your reflections, especially from the perspective as a multilateral, witnessing the burnout and trauma and the lack of coordination within a health sector, but also being able to respond in partnership to strengthen healthcare capacity, to develop those referral pathways, and strengthen medical education to lead us towards standardization and normalizing through legislation and policies better responses to GBV care. It's quite essential, and it's a model for the rest of the work moving forward. I see Dr. Filbert has a hand up. Maybe we can go to him for questions. We have about little more than 5 minutes for questions, but I have a couple questions for the panel. Let's go to Dr. Filbert first.
So thank you, Teresa. I just wanted to mention that as a country, I think Kenya has prioritized the use of digitalization as a means for enhancing community health services. And last year, the country passed the Digital Health Act. And what this has allowed us to do is to develop an electronic community health information system, which has integrated GBV. And right now, all the CHPs, the 2,423, have been sensitized. And and this platform has also integrated the provision of family planning. And therefore, we now have a backbone, a digital backbone. Each of the 100,000 CHPs across the country have been supplied with mobile phones. And there is a platform where now they are able to offer those services at the community level. So I think we needed to just mention that. But what is coming out is that there is a lot of need for mentorship, especially on those specific workflows. There are over 10 workflows within the platform. And therefore, I think we really require a lot of partnerships to be able to build this capacity. I think the platform is barely a year old in the country. And at the time of the pilot, we had not even started using the ICHIS platform. And therefore, I think there is an opportunity there for us. Now we can be able to screen for GBV at the household level. And we also offer GBV as part of the 10-day basic module for the community health promoters, though we still have a gap of community health promoters and who have been trained on the 10-day basic module. I think that is a gap that we probably need to quickly address so that we can be able to leverage on these existing opportunities that we have. I think 45% of the community health promoters are female. And as a country, we have an act that focuses on the 1/3 gender rule. And one of the key gaps that we've been having has been the governance, the leadership and governance structures for the community level. That is the community health committees for the community health units. And right now, the policy direction that the government has taken is that we are transforming the community health, the health facility management committees for hospitals, health facilities linked to the units to act as the community health committees. And a third of these, of course, are actually women. And we hope that we can be able to leave no one behind as we implement this. So there are opportunities both in terms of policy and practice for us to, improve our fight against GBV, and so that we can be able to really eliminate it and improve behavior at the household level. So I think those I just wanted to add that there is a platform, an opportunity for us, but there's a lot of mentorship review meetings that we need to engage in to ensure that we optimally utilize it. Back to you, Teresa.
Thank you, Dr. Filbert. And it's such your comments are such a good segue as we are focused on innovative community-led approaches to advancing women's health and well-being. You touch on a couple of different aspects, technology and using digital platforms, as well as looking for different ways to innovatively finance such programming as well, and leveraging the health systems. So what I'd love to explore and ask the panel, and it can be anyone who wants to reply, is just to ask if you can share more reflections as you think about this concept of innovation. What is the value of multi-stakeholder partnerships in community-based programming? And how do you think or what do you think is the best way to engage community members throughout these projects? Maybe we can start with Anna.
Thanks, Teresa. Thanks, colleagues. When we're talking about multi-stakeholders partnerships, they are critical to success and sustainability of the different programming, including our community-based programming. Because if we have strong partnership and collaboration between government agency, local NGOs, survivors-led organization, international partners, we ensure that interventions are responsible, scalable, and culturally relevant, because our work is based on the people which we serve, yeah, and our beneficiaries and individuals who received our services. And in strong collaboration, we can improve their lives. So for this approach, we need to build in trust, ensure local relevance, and strengthen our long-term impact for our interventions.
Thanks, Anna. Emmanuel?
I want to kindly beg your pardon, Teresa. I missed one or two words again. My
Therese, you are
network.
unmuted.
Sorry.
The question was just around the value of multi-stakeholder partnerships in building community-led approaches. Any reflections that you'd like to share?
Yeah, sure. Multi-stakeholder partnerships are the way to go, especially in a world where resource constraints is evident. For purposes of sustainability, lessons from this particular stepped care model point is that this has been a greatest strength that we have had in this project, because by having local government health workers at the lower health facility involved, by having the VHT structures involved, and by strengthening the capacity of other actors, and especially stakeholders, including the LOC systems, it is evident that we have been able to transfer skills, transfer knowledge, create awareness, strengthen acceptability of the project. And even in the areas where we exited, these structures have remained as a tool for a foundation for further advocacy with more awareness created. So I think bringing many partners and stakeholders on board is a key to creating more awareness, increasing advocacy in various forums. Even today, when we're discussing somewhere in some meeting, we say the district officials are able to say that no, the need for mental health care is evident, and we needed to increase our budgetary allocations to recruitment of psychiatric nurses at the lowest health facility level. So I think these have all been because we are able to bring various partners who are advocating, and there is evidence of many organizations now gearing towards ensuring that they integrate mental health interventions in any intervention that's done in the community. Livelihood intervention, there is need for mental health. Maternal child health, there is need for mental health. HIV, there is need for mental health. So I think engaging many partners and stakeholders has been very key to sounding the bell out there and strengthening structures. Thank you.
Emmanuel, Dr. Filbert.
Yeah, Teresa, I think for us as a county, we have integrated this in a piece of legislation. We have the county community, West Pokot County Health Services Act, which sets up multi-sectoral structures. And also in line with the national level policies, we now have a very vibrant primary health care technical working group, which brings together all partners in the county and the members of the health management teams. And I think, probably I would just want to appreciate HealthRight International as well, because we had a very successful primary healthcare exhibition, which was supported by all partners, and HealthRight did participate in making it a success. And we did draft a communique from this exhibition, and we are glad to report that most of our partners had really fulfilled their commitments. That's why we have fewer gaps in terms of the community health services platform. I think these technical working groups are very critical at our level to be able to keep track of commitments and to provide accountability amongst ourselves. And The other thing is that we are prioritizing the breaking down of silos and vertical programming across most of the programs in the health sector, because I think that is one of the paradigm shifts that we are actually using because we've adopted the primary care network. So we are saying that we do not want vertical programs, and we want horizontal programming and integration, so that all stakeholders are actually brought together, intervene, share experiences, and we identify where we need to support them even as government to be able to achieve their key result areas. So I think for us, we've institutionalized stakeholder coordination. It's only that we continue to suffer from inadequate funding to support these exercises. But so far, it is looking up. There's light at the end of the tunnel, and we are happy that partners are actually, supporting these engagements, and we're able to get, really improve certain areas which were hitherto quite difficult to really demonstrate change. Back to you, Teresa.
Thanks, Dr. Filbert. I think you highlighted some key issues around breaking down these silos and having integrated programming across the board, which I think is true regardless of which country we are talking about, and being able to properly codify collaboration and hold stakeholders accountable across the board. Such an important point. I realize that we are over time, so thanks everyone for staying with us. And maybe as we bring this to conclusion, I can just ask for any last reflections from our panelists about where we go from here. We've made it to these 30 years of great advancement in this global women's rights movement, and particularly in the landscape of health and well-being. But certainly there's more work to be done as we have a politically charged environment and a changing funding landscape. Where would you what would you like to share in terms of next areas of focus, priority areas of focus in the years to come when it relates to women's health? And maybe we can start with Helen.
Thank you so much, Teresa. What I would wish for us is to strengthen scalability, to scale up the community-based family planning model to other sub-counties and other counties, to ensure that family planning access is not an issue for any other woman, the poor rural woman in the marginalized communities are able to access services. And we also need to integrate other health services to community health distributors so that they are able to support and bring services closer to the community members.
Thank you, Helen. Anna?
Thank Therese. If we're talking about some next steps for a better life and for improving of women's rights, we need to understand that it must be some sustainable and systematic change across different countries, across different opportunities, also creating new services to be in line with the time and innovations which we have. Also, we need to be ensure that all our activities are safety, quality, and also empowerment and equal for everyone, because every human in this world is important. Every life is important. And from our side, we also hope for the peace, for safety sky, and for that our rights will be heard and we will be secure. Thank you.
Thank you. And Dr. Filbert?
Yeah, thank you, Teresa. For me, I think the most important thing is really follow-up, because already from what Emmanuel shared, what Helen shared, what Anna shared, and even Natalie, there is really there are innovations which have been shown to actually work. And therefore, for me, what will be key is to follow up and ensure that we scale. And that means engaging all the right stakeholders, and probably giving ourselves timelines, because we now know what works. And we could even expand that. If there are areas which we didn't get the correct data, we could do formative research and ensure that we farm up that knowledge. And of course, we really need to improve documentation of the various interventions that we are having. I think our partnerships are doing quite a lot, but there is very little that we can be able to demonstrate. Therefore, for me, I think we need to focus on documentation really of our interventions, especially those that are working, so that we can be able to better advocate for scale up. But I think we keep at it, we continue advocacy, and engaging and strengthening our coordination frameworks so that we can all move in the same direction. Back to you, Teresa.
Thank you, Dr. Filbert. And Emmanuel, any last?
Thank you very much. Personally, with all the challenges we are experiencing globally, and most notably with climate change and many other things that are going on, women, especially in low developed countries, are the most affected. And there is nothing much we can achieve in any endeavor without addressing the mental health and the psychosocial challenges that these women are facing. I think integration should be the rule, especially when we are looking at supportive interventions for women across board. With evidence from this stepped care model that integrates mental health into antenatal care, having seen the improvement, the outcomes that it has registered, I think across board, for whatever interventions, integration should be the rule. But most importantly, there is evidence that this is very scalable, and therefore there is need for more and increased advocacy, especially in terms of channeling resources towards such innovations, such that they are more scaled up. Thank you.
Thank you, Emmanuel. Thank you, panel, for all of your reflections on innovative community-led approaches to advancing women's health and well-being. This concludes today's session. I just want to say thank you to NGO CSW for this platform. A huge thank you to our speakers and discussants, Dr. Natalia and Dr. Filbert, for sharing their knowledge and experiences, as well as their dedication to supporting women's health and well-being. And a special thanks to all of HealthRight's partners that make our work possible, and to all those women and men and non-binary persons who continue to fight for gender justice globally. I wish you all peace. Thank you so much. Please enjoy the rest of CSW. Thanks for sharing your time with us. Have a wonderful day. Thank you, everyone.
Thank you.